So when we talk about strategy for the initial management of COPD, pharmacological strategy, a couple things. The GOLD 2023 report supports more aggressive initial bronchodilator therapy. So for group A, this is group A right here. The minute you're right here, they're saying, yeah, single agent long-acting bronchodilator right off the bat. If you're in group B, time to use dual long-acting bronchodilators, a LAVA-LAMA combo right up front. And you could tell when you go back a couple slides over here that in the beginning, if it was just, hey, let's just use a short acting by itself and really start using long actings right when you get to moderate. But no, we're going to use long acting up front right away. And we're also going to use dual long acting bronchodilators the minute you're going to be a group B. And definitely when you talk about group B, you should be on a dual long-acting bronchodilator. And then if you're still having or high risk for exacerbations, definitely we're going to add that inhaled glucocorticoid. If you're not and you're stable, we might not add the inhaled glucocorticoid in those cases. So with that being said, let's do a couple questions. 62-year-old man is evaluated in follow-up examination for COPD. Despite smoking cessation, adherence to his medical regimen, good inhaler TIG, and participation in pulmonary rehab, he continues to experience breathlessness and mild exertion and has diminished quality of life. He has a minimal dry cough. He has never required treatment for an acute COPD exacerbation, which is good. Meds are triple drug, fluticasone, umclenimide. Oh, these names have to stop. That's a LAMA, and Valanterol, which is a LAVA, and use albuterol as needed. Immunizations are up to date. On exam, vital signs are normal. O2 stats 93 with the patient breathing room air. Breath sounds are slightly diminished. 6-minute walk shows a minimum oxygen saturation of 91% with the patient breathing ambient air. Spirometry shows an FEV1 of 36% predicted, a DLCO of 41% predicted. Chest imaging shows upper low predominant emphysema. Which of the following is the most appropriate therapy? Well, this person's maxed out on drug therapy, already went to pulmonary rehab, and still is having symptoms. So you think we should do long-term azithromycin therapy? He's not really having a lot of exacerbations. So when we talk about medications for exacerbations, that's either going to be A or C. C is roflumilast, goes by the brand name Daliresp. And if the other option will be giving azithromycin. Of course, check for the QT interval and always worry about, resistance and pre-selecting resistance to gram positives. I don't think A and C are the right answer. Supplemental oxygen, he doesn't meet the characteristics or the criteria, to choose a better word, for supplemental oxygen just yet. There has to be a reason why they talked about upper low predominant emphysema. This would be someone that you would consider doing a consult and talking about lung volume reduction surgery. So lung volume reduction surgery, we'll talk about it, improves quality of life. It improves exercise tolerance. There's survival in selected patients who have upper low predominant disease, or one of them was more damaged than the other. Usually we like the FEV1 and DLCO to be greater than 20% of predicted and higher. These patients benefit if they have a low exercise tolerance after they finish pulmonary rehab. But of course, it's surgery, and that's what makes it really tough. And one of the things that we do instead of offering these patients surgery is, think about what they call endobronchial therapy, where you could kind of collapse the lung from the inside. So to go back to lung volume reduction surgery, if anyone doesn't really comprehend or it's kind of fuzzy, why would someone do this? Well, it's because if you have that really damaged lung, in the upper lobes, one worse than the other, if you chop it off, it's going to actually literally chop it off. It's going to get better VQ matching. Of course, there are side effects when you do these things. But the other thing they said, there's something called endobronchial valve therapy, where you place these one-way valves in the area of the lungs that have that, really bad area, and it will kind of induce atelectasis. So it's kind of like doing lung volume reduction surgery, but minimally invasive. But, for, endobronchial therapy, though it's FDA approved, they don't have the mortality data just yet. I'm sure they'll eventually get it, but that's a minimally invasive alternative to lung volume reduction surgery, which in select patients do have mortality benefit. So with that being said, I want to say a couple of statements about, hey, the role of CT, the GOLD 2023 guidelines are actually pro getting a CT in stable patients with COPD for certain reasons. If there's someone who has frequent exacerbations, excessive coughing, sputum production, maybe getting that CT to look for bronchiectasis. Maybe they need some airway clearance over there, Look at this. Maybe they can't be a candidate for lung volume reduction surgery. And here's going to be a classic CT over here where the right lung is much worse than the left, even though both lungs are horrible. We said if they're upper lobe predominant, one lung worse than the left. But look at one of my bullet points here. You can also consider a CT for endobronchial valve therapy, But there's a very special protocol you need to do for that. You talk to your interventional pulmonologist, and just yet there hasn't been any survival benefit from doing this, which I'm sure it will. And last, of course, it's unfortunate people with COPD, high risk for lung cancer. So maybe getting that CT in terms of getting your annual low dose CT for lung cancer screening in certain patients. So when to add an inhaled corticosteroid to long-acting bronchodilators. The GOLD 2023 gave us some guidance with this, which I thought was really, really nice. So these are factors to consider when adding the ICS to long-acting bronchodilators. What strongly favors the use of an inhaled corticosteroid if you're having lots of hospitalizations and exacerbations for COPD. No questions asked. If you're having more than 2 moderate exacerbations of COPD per year, if you're going to have blood eosinophils are greater than 300 cells, So maybe because there's an asthma component there, that's going to be a strong part of it. That's why the next line said, history of asthma or combined with asthma. But, eosinophils in itself have shown that story correlates with the effectiveness of having inhaled corticosteroids. So interesting. Yellow, what kind of favors do you use? If you have 1 moderate COPD exacerbation per year or your blood eosinophils are somewhere between 100 and 300 cells. What goes against the use of inhaled corticosteroids? If you're having lots of pneumonias. And of course, that was one of the side effects about giving stable patients with COPD inhaled corticosteroids, putting them at high risk for pneumonia. Or if they have very low blood eosinophils, or of course, if they have a history of mycobacterium infection, like not just tuberculosis, maybe just, MAI, Mycobacterium avium complex, or intracellular. So I thought this was kind of interesting because, when we talk about COPD or any chronic disease, you always want to talk about mortality. So the GOLD 2023 has some evidence supporting things that support a reduction in mortality with both pharmacotherapy and non-pharmacotherapy. And this was very interesting. So, number one, for pharmacotherapy, there has been studies about the LABA/LAMA ICS that show that, hey, it may improve survival. And there are a couple of trials out there. I'll put a picture of it in the next slide, talking about the IMPACT trial or the ETHOS trial. So very interesting. For non-pharmacological therapy, there's smoking cessation. So of course, combining different modalities, giving brand name Chantix, which is probably one of the most common things I use, thinking about, things like bupropion, combining with nicotine replacement, combinations with cognitive behavioral therapy, reduce mortality. Pulmonary rehab has been studies that show it reduces mortality. Long-term oxygen therapy is up there. Of course, non-invasive positive pressure ventilation. People who are discharged, who are hypercapnic and hypoxic might benefit from this. And lung volume reduction surgery. You mentioned already people with upper lobe disease. Don't forget, let me mention lung transplant should be up there. And certain people with COPD can both get a single or double lung transplant.